voided bladder, number one, initial 5 to 10 ml of urine voided. Usually, urethral flora will be determined here. And then the next one is voided bladder 2, which is the midstream. And then the third and fourth is for the flora, which is the expressed prostatic secretion after prostatic massage. And then the last is the initial 2 to 3 ml of urine after prostatic massage. S- So the second is the two aliquot. So the difference between these two is that in the second aliquot, you usually get two sample before and after a prostatic massage. So yan. For female, the standard mesonym urinalysis in the female patient should be obtained after separating the labia and the cleansing the vaginal introitus and external urethral meatus. So for patient with recurrent UTI, a catheterized sample should be obtained. And then for your neonates and infants, we use a sterile plastic bags with adhesive collars and should be attached to the infant's genitalia. Yun. So all urine samples must be exampled within 1 hour, and then if we cannot process it immediately, we can refrigerate it. I think 5 degrees Celsius can be used. And then suprapubic aspiration can also be used in obtaining a urine sample. So the next part is the physical gross examination of urine. So for the color, a normal urine color is yellow to pale yellow. And then yellow color is a result of presence of pigment urochrome. And then different varieties of urine color can be seen in different concentration foods, medications, and metabolic product infection. So in Campbell, this is the table where you can see the common causes of abnormal urine color. So there, for colorless, cloudy and milky, phosphaturia, pyuria, chylorrhea, then orange, red, green, blue, brown, brown to black. So it is all listed in our Campbell. So for next is turbidity. There are several causes of to have a cloudy urine sample. So phosphaturia. Phosphaturia is a benign process in which excess phosphate crystals precipitates in alkaline urine. And then it is often seen in intermittent and may occur after meals, and many patients are otherwise asymptomatic. So we can diagnose phosphaturia by acidifying the urine or by microscopic analysis. And then for the pyuria, it can be distinguished from phosphaturia by odor or by using urine dipstick or microscopic examination. And then these are the other causes of cloudy urine sample. So chylorrhea, lipiduria, hyperoxaluria, hyperuricusuria. So in chemical examination of urine, assessment can be done via urine dipstick. And then a common medication that may interfere the dipstick analysis is phenazopyridine. And then excess urine on the dipstick or holding the dipstick in a vertical position will allow mixing of chemicals from adjacent reagent pads on the dipstick, resulting in a faulty diagnosis. So here is this dipstick test includes specific gravity, pH, blood, protein, glucose, ketones, urobilinogen, leukocyte esterase, and nitrates, and we will discuss it individually. So for the specific gravity and osmolality, the normal value varies from 1.001 to 1.035. So a specific gravity less than 1.008 is regarded as dilute, and a specific gravity greater than 1.020 is considered concentrated. So in acute or chronic renal insufficiency, the specific gravity we can associate it is around 1.010. So Also, specific gravity reflects the state of hydration and idea of renal concentrating ability. And then next is osmolality. It is a measure of the amount of material dissolved in the urine and usually varies between 50 to 1,200 milliosmoles per liter. So next, second part is the pH. So the pH range from 5 to 9. The urinary pH reflects the pH in the serum. So urine pH determination are also useful in the diagnosis and treatment of UTIs and urinary calculus disease. And then urinary pH is usually acidic with patient with uric acid and cysteine lithiasis. Other notes. Wait. Mm. So in patient with metabolic and respiratory acidosis, the urine is usually acidic. Conversely, in patient with metabolic and or respiratory alkalosis, which is the urine is alkaline. And then in patient with a presumed UTI, an alkaline urine with pH greater than 7.5 suggests infection with a urea splitting organism. Mostly common is the Proteus. Next, RBC. A normal urine should contain less than 3 RBC per hyper power field. A positive dipstick for blood in the urine indicates either hematuria, hemoglobinuria, or myoglobinuria. And then hematuria can be distinguished from hemoglobinuria and myoglobinuria by microscopic examination of the centrifuge urine. The presence of a large number of erythrocytes establish the diagnosis of hematuria. And then if the erythrocytes are absent, so it can be distinguished as hemoglobinuria or myoglobinuria. So what are the differential diagnosis of a hematuria? So identifying the hematuria as nephrologic versus urologic and glomerular versus non-glomerular is one of the first step in the analysis. So yan. So erythrocytes from glomerular disease are typically dysmorphic with wide range of morphologic alteration. Meanwhile, erythrocytes from interstitial renal disease and of urologic origin have a uniformly round shape. So yun yung difference in shape. So for glomerular hematuria, uh, presence of dysmorphic erythrocytes, RBC cast, and then proteinuria. So, so in the book, this is a schematic diagram of glomerular hematuria. So there you can see if there's rash and arthritis, we can consider systemic lupus erythematosus, and then ayun, different diseases. Next. For non-glomerular hematuria, usually we can distinguish it in of the presence of circular erythrocytes and then the absence of erythrocyte casts. So we can categorize non-glomerular hematuria into two categories, which is medical and surgical. So asymptomatic microscopic, there is such thing as we call this asymptomatic microscopic hematuria. It's defined as 3 or greater RBC numbers per hyper power field on a properly collected urinary specimen. So next, proteinuria. Healthy adults excrete 80 to 150 milligrams of protein in the urine daily. So it composes of 30% albumin, 30% serum globulins, and then 40% tissue proteins. What then next is the pathophysiology of proteinuria. Mhm. So first is glomerular proteinuria. So it is the most common type of proteinuria and results from increased glomerular capillary permeability to protein, especially albumin. It occurs in any of the primary glomerular diseases such as IgA nephropathy and glomerular systemic illness such as diabetes mellitus. So, a glomerular disease should be suspected when the 24-hour urine protein excretion exceeds 1 gram and is almost certain to exist when the total protein exceeds 3 grams. So, for tubular proteinuria, it is a failure to reabsorb normally filtered proteins of low molecular weight such as immunoglobulin. So, disorders that lead to tubular proteinuria are commonly associated with other effects of proximal tubular functions. So the third one is overflow proteinuria. It occurs in the absence of any underlying renal disease and is caused by increased plasma concentration of abnormal immunoglobulins and other low molecular weight proteins. So the detection for proteinuria, qualitative detection of abnormal proteinuria is most easily accomplished with a dipstick impregnated with tetrabromophenols blue dye. And then protein electrophoresis is particularly helpful in distinguishing between glomerular from tubular proteinuria. And then for the evaluation, uh, proteinuria should be first be classified by its timing. So the three again, transient, intermittent, and persistent. Transient proteinuria commonly occurs in pediatric population and resolves spontaneously within a few days. And then proteinuria, which may also occur intermittently and related to postural change. Meanwhile, persistent needs further evaluation. So I think ayan, this is the another diagram where we can further evaluate those patients with proteinuria. So again, there are transient, persistent, and the intermittent. And then under it, there are different steps that we can use in diagnosing and evaluating proteinuria. Yan. We can see it in Campbell book. Next. Then for glucose and ketones, glucose detection with the urinary dipstick is based on a double sequential enzymatic reaction. And then ketones are not normally found in the urine but will appear when the carbohydrate supplies in the body are depleted and body fat breakdown occurs. Next, bilirubin and urobilinogen. Normally, urine contains no bilirubin and only small amounts of urobilinogen. So we have two types of bilirubin, direct and indirect. And so, and then lastly, urobilinogen is the end product of conjugated bilirubin metabolism. Next, leukocyte esterase activity. It indicates the presence of white blood cells in the urine. And then, if there is a presence of nitrites in the urine, it suggests of a bacteriuria. Then major cause of false positive leukocyte esterase test is specimen contamination. Ayan, so another diagram. So, next. So how do we obtain and prepare the specimen if we're going to check urinary sediments? So again, within 1 hour, we should examine the urine. And then for female, catheterized urine sample can be obtained for culture and sensitivity. So last part is the microscopy technique. So here we have cells, casts, crystals, bacteria, yeast, parasites, and then another express prostatic secretions. I will show you pictures, examples of each. So cells, erythrocytes morphology may be determined using a high power field magnification. And then it sometimes can be confusing with yeast and fat droplets. So in normal microscopy technique, normal to find 1 to 2 leukocytes per high power field. And then for female, 5 per high power field in women whom the urine sample may be contaminated. So, a greater number of leukocytes generally indicates infection inflammation. So this is a example of a red blood cells, both smoothly rounded and mildly crenated, typically of epithelial erythrocytes. And so another example, pero this one is with patient with bladder tumor. Different. For CAS is a protein coagulum that is formed in the renal tubule and traps any tubular luminal contents within matrix. So a TAM horse-fall mucoprotein is the basic matrix of all renal casts, and it originates from tubular epithelial cells. Mm, So another cast is fatty cast, seen in nephrotic syndrome, lipiduria, and hypothyroidism. Then for granular and waxy cast, degeneration of cellular elements. So yeah, example of a hyaline cast. Another example, this is RBC cast. Then this is granular cast. And examples. So for crystals, identification of crystals in the urine is particularly important in patients with stone diseases. So identification of cystine cells establish the diagnosis of cystinuria. So bacteria, a normal urine should not contain bacteria. And then 5 bacteria per high power filter reflects colony counts of about 100,000. So it's an example of streptococcal urinary tract infection with typical chain formation. So here yung arrow. So this is another example of a gram-negative bacilli or Escherichia coli. So for yeast, next part, the most common yeast cells found in urine are Candida albicans. And then we can distinguish it by budding and hyphae can be noted. So here is another picture of a Candida albicans. Budding forms. So for parasites, Trichomonas vaginalis is the frequent cause of vaginitis in women and occasionally urethritis in men. So here is a picture of an ovoid shape and motile flagella. Here. Yeah. Next. So last part of the microscopy technique, the express prostatic secretion. And then it should be examined in male patients who is suspected to have prostatitis. Normal prostatic fluid should contain few leukocytes, and the presence of large number of clumps of leukocytes is indicative of prostatitis. And another example of oval fat macrophage in a secretory granule in the prostatic fluid. So what are the key points? So a catheterized urine specimen should be obtained in the female patient with a history of recurrent UTIs and contaminated specimen. And then hematuria should be stratified into glomerular, non-glomerular, medical, and surgical causes. Then dipstick alone is inadequate for the diagnosis of microscopic hematuria. Ayun, earlier, yan. Symptomatic microscopic hematuria. So next is serum laboratory studies. So serum creatinine and calculated glomerular filtration rate is often used to assess baseline or current renal function. So meron here formula. So this is the formula of estimating glomerular filtration rate. So the Cockcroft-Gault formula. Next. So PSA or prostate specific antigen. It is used in the diagnostic evaluation of prostate pathology, including cancer, BPH, and inflammatory conditions in the prostate. So, so urinary markers. So urinary cytology is ordered when urothelial malignancy is suspected. It was considered a standard part of the screening for urothelial cell carcinoma. It is not recommended. Wait. Okay. Okay. So again, key points, same. Last part of his diagnostic procedures. So uroflowmetry and ultrasound for post-void residuals. These are useful tests to obtain some basic information of the voiding status of the patient. And then uroflowmetry is performed in the office with the patient voiding either in a standing or seated position. So, ayan, picture on how we can use the uroflowmeter. Then cytourethoscopy. It is ordered when direct visualization and evaluation of the lower urinary tract is required. So the most common reason is to diagnose of lower urinary tract malignancy, obstruction, or other cases to assist with insertion of a urethral catheter. So routine use of antimicrobial for prophylaxis is not recommended for cytourethoscopy and urodynamics or cytography with patient with risk factors. So in our book, we can see the lists of uh, those factors, like five. So so this is a cytouteroscope for female, flexible siya. Next. So for ultrasonography, it is used to obtain information on the size and shape of the kidneys, absence of hydronephrosis, cyst masses. Mhm. And then it is not sufficient as a standalone imaging study for the workup of hematuria, and other cross-sectional abdominal imaging should be considered. Ayan. CT scan and then MRI. So the basic indication for ordering them in patients are when condition of the upper tract and bladder are suspected. So non-contrast CT scan is the most sensitive test and the gold standard for the detection of urinary stones. Yeah. MRI is not useful in the diagnosis and follow-up of urinary stones. And then intravenous pyelogram and plain radiographs. A KUB may be ordered in the initial evaluation and follow-up of non-emergent patients with a urinary stone in the ureter or kidney. So, ayan, key points again. So, CT scan without contrast is the gold standard again for urinary stones. And thank you.
Okay, thank you, Dr. Kaiko. Naikin ba kayo? Meron akong tanong. Dr. Kaiko,
Yes, sir.
you mentioned kanina na yung asymptomatic microscopic hematuria.
Yes, sir.
Nakalagay doon sa key points mo pero pinadaan mo lang eh. Nakalagay doon urinary cytology hindi siya routinely recommended in patients with asymptomatic microscopic hematuria.
Yes, sir.
O so kunyari GP ka na. May dumating sa'yo nag-complain dysuria, lalaki. Tapos nagpakita siya ng urinalysis sa'yo. Nakita mo 'yon. May microscopic hematuria. Ano yung gagawin mo?
Papa urinalysis nakita na.
Ano yung una mong gagawin?
Anong gagawin? Wait lang, sir. Ano ba?
Ay, mabilis. Magtatahi siya ng cancer. Kaya
Okay.
urinary bladder cancer na, hematuria. Tapos urinalysis niya, malinis yung pus cells, mag-order ka ng urine cytology pa din. Kahit hindi siya
Okay, sir.
recommended. Kasi may history ka ng bladder cancer. Kung wala, asymptomatic talaga, walang symptoms, nagpa-urinalysis, routine evaluation lang, nakita mo, microscopic hematuria pa din, anong gagawin mo? Walang symptoms.
Double check.
Ha?
Papatest ulit, sir.
Hindi. Mag-order ng kung mag-expect ka ng cancer, mag-suggest ka ng cystoscopy. Pwede ka mag-suggest ng cystoscopy and urogram, CT urogram to detect lang ng cancer kung meron. Saka yung sinabi mo kanina na yung this is the picture of a cystourethrogram, nilagay mo for females flexible. Hindi. Kasi yung pictures mo kanina, may edits yun eh, tapos naka-flexible. So yung flexible cystoscopy applies to all.
Okay, sir.
Okay. Next.
Yeah, just want to comment. That's very good points by Dr. Poa. So usually, yeah, for upper tract imaging, okay. For cases with, for patients that you are suspecting malignancy, like for example, yung sinabi ni Dr. Kowa, known case of bladder cancer, actually hindi lang bladder cancer, for any upper tract tumors, kidney, ureter, you may request for a cytology, upper tract imaging, and an office cystoscopy. So yung tatlong points na yun na sinabi ni Dr. Kowa. And those were good slides too. How I wish we could show you here sa office how we do it, yung cystoscopy. Lagi kaming nag-cystoscopy, including yung Euroflow din na pinakita kanina. Parehas na parehas yung ginagawa namin. So hopefully ma-experience nyo or makita nyo or kayong mag-conduct mismo dito ng mga laboratory. But yeah, those were good points by Dr. Ko. The next speaker may proceed.
Good morning, doctors. I'll be discussing the basic principles of nuclear medicine in urinary tract imaging. This topic mainly focuses on the different radio tracers used in urology and its application, which may include the measurement of renal blood flow, determination of renal function, and also clear cancer type. Nuclear medicine utilizes pharmaceutical agents and radionuclides to visualize organ function, treat disease, and characterize molecular processes within cells. On your left side is an example of a renal scan, and on the right side is a PET scan. Both of these are an example of nuclear imaging. Radiotracers are the imaging agents used in nuclear medicine and are generally administered in subpharmacological quantities such that they do not perturb the processes that they are being used to measure. And it emits radioactivity that can be detected by an external sensor unit, and the data received by the sensor can then be formatted as an image for interpretation. The tracer is usually injected into a vein. Principles of single-photon and PET, or the positron emission tomography imaging. SPECT and PET can provide three-dimensional images and are typically performed in combination with a non-contrast CT, allowing anatomic localization of the detected radioactivity, because the main focus of SPECT and PET are the functional and metabolic properties of an organ. So for single-photon emission computed tomography, or SPECT, it detects radionuclides that emit low-energy gamma photons. And this is also the imaging technique used in renal scan or scintigraphy, where function of the kidneys is being evaluated. It requires gamma camera, and the gamma camera is composed of a scintillation crystal, which is usually made of sodium iodide, which absorbs gamma photons and emits light. A photomultiplier tubes which collect and amplify the light emitted by scintillation crystal, and a circuitry which integrates the output from the photomultiplier tube into information that can be reconstructed as an image. A collimator, which is placed between the patient and the detector crystal, will encode spatial information. SPECT will only allow semi-quantitation, and the commonly used radionuclides are technetium and indium. For PET, this will detect radionuclides that emit positrons. The emitted positrons travel a short distance before colliding with a nearby electron, causing annihilation event, leading to the release of 2511 keV photons traveling 180 degrees apart. Then the images are constructed. The commonly used radionuclides are carbon, iodine, fluorine, and gallium. The main difference between SPECT and PET is the radio tracer being used. The advantages of PET over SPECT are the following: highest level of spatial resolution, highest degree of visual conspicuity, ability to quantify the degree of radio tracer uptake within areas of interest, and the limitations of PET are higher cost and limited access. At the present time, the majority of functional imaging tests in urology are performed with scintigraphy or yung renal scan, and cancer imaging is most often performed with PET in combination with CT and MRI. Functional imaging of the kidneys. The common applications of radio tracers include measurement of renal blood flow, determination of differential renal function, evaluation for the presence and degree of renal obstruction, and assessment of renal scarring. On average, the kidneys receive 20% of cardiac output. A healthy individual weighing 70 kilograms, cardiac output averages 5 liters per minute, making the total blood volume received by the kidneys equal to 1 liter per minute. 20% of plasma clearance occurs by passive glomerular filtration, and the remaining 80% occurs by active tubular secretion. So the mechanism of clearance from the blood and the timing of excretion from the kidney determines the clinical information that each radio tracer can provide. The most commonly used radio tracers for functional renal imaging are the following. So first, technetium 99M, diethylene triamine pentaacetic acid or TCDTPA, which is used to evaluate relative renal plasma flow and functional renal obstruction. This is excreted by the kidneys through glomerular filtration, and then the drug moves quickly through the renal tubules and excreted into the urine without being reabsorbed. And because of this mechanism, it can be used to calculate GFR, the glomerular filtration rate. Next is technetium 99M, mercaptoacetyl triglycine, or the TCMAG3, can be used to determine the renal split function and to assess for functional obstruction. So renal split function is used to determine the relative function of each kidneys. And this is protein bound in circulation and undergoes clearance through tubular secretion. It has an improved image quality and lower radiation doses. Thus, this is the agent of choice for measuring differences in renal plasma flow and to assess functional obstruction. Last is technetium 99M, dimercaptosuccinic acid. This is cleared from the plasma primarily by glomerular filtration and undergoes receptor-mediated endocytosis by the proximal tubular cells. This is retained by the proximal tubular cells. This is the imaging agent for cortical processes such as acute pyelonephritis and renal scarring. For patient preparation, the patient should be well hydrated. Take note of any medications that the patient may be taking that can impact the examination and its interpretation. For example, is the blood pressure lowering medications. Note any known or suspected anatomic abnormalities that may impact the patient positioning as well as the placement of gamma camera, history of neurogenic bladder or bladder outlet obstruction. Dosing and pharmacokinetics, 2 to 5 millicurie of TC-MAG3 via IV push and 5 to 10 millicurie for TCDTPA. 60% of the peak cortical uptake is observed 3 to 5 minutes after IV injection, and shortly thereafter, regiotracer is seen within the renal collecting system. And by 10 to 15 minutes, bladder can be visualized as a regiotracer is excreted into the urine. 15 to 20 minutes is the peak of activity to half of the regiotracer being cleared from the collecting system, or this is also known as the half clearance time. And this is indicative of a non-obstructed renal unit. For image acquisition and interpretation, renal imaging is performed in two phases. We have the perfusion phase and the functional phase. So for the perfusion phase, the renal plasma flow to each individual unit is measured and compared with flow within the aorta. Images are acquired every 1 to 2 seconds, and the data are recorded as the number of total photon counts, also known as activity per unit time, which is plotted on the time activity curve. So this is the time activity curve, and on the x-axis, we have the time. On the y-axis is the total activity. The shape of the curve for each kidney, the purple and the tail curve, representing the right and left kidney, should roughly match that of the aorta. So yun yung white curve dito. So the curve with a slow rise to peak may indicate an underlying poor renal function. For the next phase, we have the functional phase in the lower half. This is the comparison of the individual renal curves, which will allow the determination of relative renal plasma flow. So the relative function of each kidney is determined by measuring the area under the time activity curve between 1 and 3 minutes post-injection of the regiotracer. The curves for each kidney are roughly parallel in both shape and magnitude. A split function difference of up to 10% is considered normal. So with good renal function, regiotracer is clear within 15 minutes. And an obstructed renal unit, there will be retention of regiotracer in the collecting system with a gradually upsloping time activity curve with no peak. Some patients may experience delayed clearance from the renal pelvis, although they do not have a truly obstructed system. A patulous collecting system and ureter as a result of a previously repaired obstructed process such as UPJ obstruction. IV furosemide is given in order to differentiate these patients from those with obstruction. 0.5 milligram per kilogram of body weight to a maximum 40 milligrams is the recommended dose of IV furosemide. A post-furosemide half clearance time of less than 10 minutes may indicate a patulous non-obstructed system. More than 20 minutes may indicate an obstruction, and between 10 to 10 minutes is indeterminate, and further evaluation is warranted. So here is an example of a normal renogram of a patient with a history of hydronephrosis being evaluated for obstruction. In the upper half, we have the perfusion phase, which demonstrates the movement of regiotracer from the site of injection to the aorta and the kidneys. So here, the white curve reflects the aorta. The purple and tail curve reflects the activity within the kidneys. So we can see here that the shape of the curve roughly match that of the aorta, indicating a good flow or a good perfusion within the kidneys. And in the lower half, we have the functional phase, which demonstrates the movement of the regiotracer from the collecting system as it transitions down to the ureter and the bladder. And this is also confirmed in the time activity curve. There's also a peak regiotracer uptake, approximately measuring 3 to 4 minutes. And there's also decreasing curve, which may indicate that the collecting systems are draining. And here we can see that the split function in the left kidney is 46% and in the right kidney 54%. 94%. So within normal siya, percent renal split function difference. So second figure, this is the renogram of a patient with the history of a bilaterally repaired ureterocells and persistent hydronephrosis without functional obstruction. In the upper half, we can see here that the purple curve representing the right kidney has a less brisk upstroke compared to the left kidney, which may indicate that there's a poor renal function. And here in the lower half, we can also see here that there is an increasing radiotracer uptake and a delayed in washout. So because of given delayed washout, an IV furosemide of 40 milligrams was given. So here upon administration of IV furosemide, you can see here that there is a significant response as confirmed in the time activity curve as the both collecting systems drain promptly. And the half clearance time is 5 minutes for the left kidney and only 6.2 minutes in the right kidney. So indicative of a non-obstructed patulous system. So for the third figure, this is the renogram of a patient with a right-sided renal obstruction. So in the upper half, we can see here that the tail curve or the left kidney has a sharper curve compared to the purple curve or the right kidney. And also the white curve representing the aorta has an irregular curve, which is secondary to the scoliosis of the patient. And here in the lower half, the functional phase, we can see here that there's also a delayed and an increasing uptake of radiotracer within the initial 30 minutes of administration. And because of the typical pattern of the right-sided renal obstruction, an IV furosemide was given, and we can see here that there is no significant clearing after furosemide administration. And the half clearance time is 22 or 23 minutes, so more than 20 minutes, and this may indicate renal obstruction. Additional applications of TCMAG3 and TCDTPA scintigraphy. First, for the evaluation of renal vascular hypertension. This is used to differentiate between renal vascular hypertension and essential hypertension. TCDTPA is used for this application as it is cleared from the blood exclusively by glomerular filtration. And patients are imaged using a 2-day protocol. On day 1, patients are administered a dose of oral captopril. Captopril is an ACE inhibitor, and in patients with renal artery stenosis, there is a constant activation of RAAS. So if we give the patient an oral captopril or an ACE inhibitor, the RAAS will be inhibited. So hindi ma-maintain yung renal blood flow and glomerular filtration. So there will be a decreasing filtration pressure and peripheral vasodilatation, resulting now to the slow uptake of radiotracer and low peak activity. So for those with an abnormal curve, a second study is performed 1 to 2 days later. So no ACE inhibitor or CCB. Improvement in renal function by 10% has a high probability of renal vascular hypertension. For renal transplant evaluation, for acute rejection or delayed graft function secondary to prolonged ischemia during organ harvesting. So for acute rejection, there will be decreased renal perfusion, and on serial imaging, it will worsen with time. And for delayed graft function, normal perfusion is maintained and longitudinal improvement is observed. Evaluation of anastomotic leak, which can be seen as collection of radioactivity outside of the kidney. For assessment of vesicoureteral reflux, which occurs commonly in children, we can use it to monitor the presence and degree of reflux. fluoroscopic voiding cystourethography should be used in the initial screening of VUR because scintigraphy will provide little anatomic information, and children with history of UTIs should also be evaluated for posterior urethral bulbs and bladder diverticula, which can only be detected with the combined anatomic and functional information from a fluoroscopic voiding cystourethrogram. And lastly, renal cortical imaging with TCD-MSA. The MSA is retained by proximal tubular cells, allowing for visualization of the renal cortex. This can be used for evaluation of suspected pyelonephritis and detection of renal scarring. So for normal imaging, the renal parenchyma will appear homogeneous and smooth, and in areas with acute inflammation or infection, the defects will appear with low levels of regiotracer uptake, and areas with scarring, so there will be areas without regiotracer uptake, and it will have a sharper borders and are commonly seen in atrophic kidneys. For infection imaging, infections of the genitourinary tract can often be readily identified on the basis of clinical signs, symptoms, and localizing culture data, but this is not true in pediatric patients and patients with neurologic conditions. TCD-MSA is the most widely used radiotracer for imaging infections of the kidney. So white blood cells labeled with indium-oxine. So usually the labeled white blood cells will accumulate in the hematopoietic system, with other sites of uptake generally indicating the presence of active infection. Evaluation of intra-abdominal infections, which is helpful for patients without localizing symptoms or convincing findings of a collection on conventional imaging. And WBC is labeled with HMPAO. This is cleared in urine in the hepatobiliary system, which is challenging when evaluating for sites in close proximity to the genitourinary tract. This is preferred for pediatric patients because of more favorable dosimetry. Regardless of the radiolabeling method, TUG white blood cell imaging cannot be used when assessing transplant kidney because of a large fraction of the white blood cells will accumulate in the renal graft. So molecular imaging of genitourinary malignancies, PET radiotracer, or the 18-fluorodeoxyglucose is taken up by malignant cells, which commonly shunt energy production from oxidative phosphorylation to lactic acid fermentation, which is also known as Warburg effect. So what happens here is that the 18-fluorodeoxyglucose, which is a glucose analog, is taken by metabolically active cells via GLUT1. And once within the cell, FTG is phosphorylated by the glycolytic enzyme hexokinase, preventing diffusion back across the cell membrane. So the trapped FDG molecule, which are missing a 2-hydroxyl, cannot undergo further metabolism. And the remaining intact FDG molecule will now allow the detection with PET imaging. A number of genitourinary malignancies can be successfully imaged with FDG, including urothelial carcinoma, renal cell carcinoma, squamous cell carcinoma of the penis, and testicular germ cell tumors. Genitourinary tract is partially obscured by urinary excretion of fluorodeoxyglucose. Imaging with this radiotracer is reserved for the detection of distant sites of disease. Prostate cancer uncommonly shuns energy production towards aerobic glycolysis and therefore is poorly visualized. So first we have the bladder cancer. Current guidelines do not support the use of FDG in patients with otherwise clinically localized bladder cancer, as it remains unclear if the detection of extravesical disease on molecular imaging alone changes outcome. PET imaging of the bladder is only indicated in cases of equivocal conventional imaging or as a confirmatory test when a biopsy is not possible. It can also be used to image urothelial carcinoma of the upper urinary tract for detecting distant sites of disease. However, CT urography is still the mainstay of imaging localized upper tract urothelial carcinoma. So this is an example of a patient with metastatic urothelial carcinoma of the bladder. For kidney cancer, recurrent or metastatic renal cell carcinoma, it has highest level of sensitivity for detecting sites of extrarenal type 2 papillary renal cell carcinoma. Current guidelines, however, recommend against the use of PET for staging or follow-up of renal cell carcinoma as the clinical benefits remain unclear, and most cases of renal cell carcinoma are the clear cell subtype, which shows lower levels of FDG PET. And the prostate cancer has a little role in imaging prostate cancer. Imaging is most commonly performed with a combination of contrast enhanced CT, MRI, and bone scintigraphy because prostate cancer cells has a low uptake of radiotracer, which is secondary to the decreased metabolic activity of the prostate cancer cells. And the carbon-choline is the first radiotracer to be approved by the FDA, which is reliable in detecting sites of disease with increasing sensitivity at higher PSA levels. It doesn't have a role in characterizing primary prostate cancer, as uptake can be seen in areas of inflammation within the prostate. So these are the radiotracers used for prostate cancer imaging. And penile cancer, FDG PET can be used for confirming the presence of metastatic disease and determining the relative extent of nodal involvement in patients with palpable lymph node. And lastly, testis cancer for men with a residual mass after treatment with chemotherapy, because this will help differentiate fibrosis from a residual active tumor. However, for non-seminomatous germ cell tumors, PET imaging is not indicated, as there appears to no clinical benefit over the combination of CT and serum markers. Yun lang po.
Yeah, thank you. Hello?
Hello po, sir.
Yeah, we were just commenting. That was a very good lecture. Medyo high-level stuff, but very good. We were just commending your lecture. I know this is to you, but these are actually practical examinations that we can do, especially where the part where you check the GFR scan. I do understand we don't have SPECT or PET CT scan, but yeah. Doctor, can you give example of a practical reasons where we can use a GFR scan based on your presentation?
For example po, Doc, if the patient has obstruction po, Doc, renal obstruction.
So do you, yeah, go.
Or in cases po of glomerulonephritis po, Doc.
Yeah, let's start with your first example. So do you do a GFR right away if there's an obstruction, or what do you do first before you test for GFR? Yeah, I'll answer it for you. Before we do those scans, we usually unobstruct the patient. So whether it may be a percutaneous drain or stenting endoscopically, or we take out whatever is obstructing, and then from then on, you let the nephrons rest for a month, and then you ask for the scan, for the GFR scan. So that way, you get an actual value. Because yung mga obstruction na sinabi mo, pag nagpa-scan ka dyan, obviously, wala siyang function. Or poorly function because it's obstructed. So that's why I wanted to point out what practical reasons you may use this. As for the PET CT, personally, I have no experience with that, although it's still important in probably first world countries. Do we have any more comments from the others? Medyo high level stuff siya eh. Pero as you go along in internship, I hope you guys get familiar with these terms, including yung first lecture, kasi yung mga values kanina, yung sa UTI, Yeah, as an intern, hindi na yung positive lang, may UTI. So we need values for diagnostics as much as possible to get. Lang enumerate yung GFRs. So ano ba yung level nun? Yung ESTR.
Sorry po, sir.
Can you enumerate yung pag kailan ka end stage, yung GFR mo? Do you have values for that? Yeah, di ba you mentioned yung Cockcroft formula? So, hindi lang euro yun eh. Usually, they mention that sa medicine. So, can you give us that? Yung 5? It should be there.
For stage 1,
Yeah.
power of more than or equal to 90.
Okay.
For stage 2, 50 to 89. 60 to 89%. And for stage 3 po, sir, 30 to 59%. Stage 4, 15 to 29%. And stage 5, less than 15%.
That's good. Because the reason I mentioned it, it's because those are the values you get, not just from your computation, but from your GFR. Gets?
Opo,
Okay.
thank you po, Doc.
Thank you. By the way, guys, hindi ko pa nasisend sa inyo, but we have an evaluation form for you guys. So, I'll probably send it to Camille probably later para may guide kayo dun sa reports nyo. So may guidelines talaga tayo for evaluation. Next lecture, are you guys ready na ba? Thank you.
Good morning, doctors. I am Jovira Digrano, and I'm about to report about the principles of urologic surgery, incision, and access. Urologists are experiencing less exposure to traditional surgical techniques because of expanding era of experience, training, and indications for surgical robotics and laparoscopy. Open incisions remain unpopular when there are minimally invasive alternatives. However, there remain some indications for open surgery, such as prior abdominal surgeries. Therefore, we should all know the basic understanding of open incision. So first, let's start with the abdominal.
Doktora?
Yes po.
Palakasan ko.
Okay po. So first, let's start with abdominal incision. Under abdominal incision is the midline incision, which is commonly used abdominal incision. Extraperitoneal, peritoneal, and retroperitoneal spaces can be accessed here. And the lower midline incision, which is just below the umbilicus, is also known as infraumbilical, which provides access to pelvic organs. So this is the lower midline incision. And the upper midline incision here gives access to retroperitoneal structures bilaterally. So various lengths are used depending on the procedure. It can be extended inferiorly or superiorly past the umbilicus to improve exposures and access to abdominal and retroperitoneal organs. Also, one should identify the linea alba upper new abdominal muscles in the midline and incise along it to avoid cutting through the rectus abdominis muscle. This can avoid bleeding and risk for Yeah, there's for bleeding. Sorry. In midline incision, usually it is closed in one layer. The closure of the initial layer layer directed figure of eight fashion. Careful surgical technique is critical to avoid injury to the abdominal structures and to ensure strength of the wound. Suture should be 1 cm from the midline and 1 cm apart, just like here in the picture. Next is the fan and steel incision. As we all know, this is the most common incision used in cesarean section in OB. However, it is also suitable for both extraperitoneal and intraperitoneal um, pelvic sutures, surgical. Lower rates of morbidity and incisional hernias occurs here in this incision compared to the midline approach. The transverse semilunar incision is made 2 finger breadths above the pubic bone here, and the anterior rectus sheath is open transversely, and the muscle above and below other side of the midline is bluntly separated from the sheath. So that is the picture. And in this incision, it can be extended laterally for more exposure and can be extended into a Gibson incision, which will be discussed later. And for the closure, the peritoneum and the muscle are approximated, and the fascia is closed with a running or figure of eight absorbers. So this is the Gibson incision. It is the traditional approach for renal transplant and transplant nephrectomy. It provides great extraperitoneal access to pelvic vessels, lower ureter, and bladder. So the traditional pelvic Gibson incision is an oblique, um, curvilinear incision from a few centimeters medial to the axis, extending downward to the inguinal fold or continued the above the symphysis pubis. Next. Recently, this incision has been modified to be more J-shaped or hockey stick shape. However, they may found that this incision may lead to higher rates of hernia, mostly incisional hernia. So next, the anterior approaches to the kidney and retroperitoneum. So the anterior incisions provides access to the kidney or retroperitoneum with their own advantages and disadvantages. So for the upper abdominal incision, which is commonly used in pediatric renal surgery, the paramedian incision, which is less commonly used in adults, can risk injury to nerves within the rectus and predispose to ventral hernia. So this is the transverse abdominal incision, and the paramedian is for the thoraco-abdominal incision. This incision indications for this incision may have been decreased, probably because of the large and morbid incision compared to the other abdominal incisions. However, this incision provides excellent exposure to adjacent thorax, retroperitoneum, and great vessels. So for this incision, the patient is placed in an exaggerated plank position with the arm on the side being operated on elevated and secured Mayo stand. The incision is made above the ninth to 10th rib bed depending on the pathology, either supracostal or removing a section of rib and extended into the abdomen. Extension may be uh, it can be extended to the midline if needed. So alternatively, a modified thoraco-abdominal incision can be done by performing the thoracotomy through the 8th rib bed and combining a subcostal incision with a standard longitudinal abdominal incision. Muscles are incised and the pleura opened with care not to injure the underlying lung because this incision is pretty large and it can affect the other organs underlying. The diaphragm can then be opened to conjoin thoracic and abdominal cavities to end the costochondral junction. Another example is the chevron and subcostal incision. Under this, the subcostal transperitoneal, this approach, this is um, this incision approach is the kidney to address kidney masses with associated caval thrombus. And the supine subcostal incision may be used to address larger, more anterior tumors where access to the hilum may be better controlled than the flank subcostal approach. Just to show you a better show you the difference between chevron and subcostal incision. The subcostal incisions mainly starts just below the margin of the just below the subcostal margin here. And if we're using the chevron, it's just go along the other side. Just just the same as the subcostal. Here, the patient may be in supine or modified plank position. The incision is generally made from the midline 2 finger breadths below the costal margin, extending laterally as far as the tip of the 11th rib. And next is the flank incisions. There are multiple flank and modified flank incision used by the urologist. And careful techniques are used to avoid long-term complication and post-operative pain. Operative pain often involve incisions of the muscles or removal of parts of ribs. And these incisions require dissection through three muscles and fascial layers: the external oblique, internal oblique, and the transversalis muscles. And under flank incisions is the through flank incision. Here, the patient is in a plank position, which is a lateral recumbent position with the lower leg flexed and upper leg extended, which creates a convex extension of the upper side, which is the operative side of the body. The area of incision then is placed over the break in the table to better open this area. Next is the 12 rib and 11 ribs of transcostal. These are the traditional flank incisions, and they allow for more comfortable retroperitoneal access posteriorly, therefore decreasing the risk for associated bowel complications. However, they inherently increase the risk for thoracic complications, including pleural injuries. Next is the inguinal incisions. Um, there are multiple indications for utilizing inguinal incisions in both pediatrics and adult patients. These procedures usually require access to spermatocord, whether for the management of cryptorchidism or the undescended testes, and synchronous hernia repair or oncologic procedures such as partial or radical orchiectomy. Inguinal incisions is most commonly used for radical orchiectomy in the adult population. A 5 to 7 centimeter cm curvilinear or transverse incision is made beginning 2 cm cephalad and lateral to the pubic tubercle. A similar incision can be used for inguinal varicocele and for exploration for cryptorchidism. Incisions above the inguinal ligament. Here, there is careful dissection is essential to avoid injury to the inguinal nerve spermatic cord structures. When closing these incisions, the internal and external oblique muscles should be reapproximated to close the inguinal canal and create an external ring. So for the incisions for inguinal and for pelvic lymphadenectomy in penile cancer, here the extent of positive disease or desired dissection will determine which incision is performed. They can be unilaterally for an extended or modified inguinal lymphadenectomy. The standard is a much larger incision and is associated with significant complications including wound infection and lupus. So the basics of inguinal incision is parallel to the inguinal ligament is the most common, and it is used exclusively for urology for lymph node dissection and extensive penile cancer metastasis. Typically, the skin is incised obliquely from the axis to the pubic tubercle, 2 cm below the inguinal ligament, parallel to the groin crease, as what's shown in this picture. Incision for specific surgeries. The posterior lumbodorsal incision or dorsal lumbotomy. The lumbodorsal approach to the kidney was used to, as it had multiple benefits over flank incision and the anterior transabdominal approaches, mainly because of the lack of muscle or distortion in this type of incision. This incision allowed for good exposure and less post-operative pain, decreased hospitalization, more rapid convalescence, and ease of closure. So classically, it is used for benign surgeries in adult and pediatric populations, such as open upper tract urolithiasis, open renal biopsy, and pre-transplant nephrectomies. However, in modern times, this incision is mostly used for pediatric. And the incision itself is muscle sparing and has minimal risk for complications. And traditional contraindications in this incision includes malrotation of the kidney, renal fusion abnormalities, severe spinothoracic deformities, and malignancy. So here, the patient is positioned in a lateral axis of 45 degrees in position. Um, the incision will start from 2 to 3 finger breadths, just lateral to the spine, with a 3 to 5 cm incision starting from the costovertebral angle as high as the 11th rib. And then the incision will obliquely, the incision will start here, then going obliquely towards the iliac crest or sacroiliac. For the approach of posterior lumbodorsal approach to the adrenal glands, instead of the lateral position, the patient is now in a prone position, and this is used to access the bilateral extraperitoneal to the adrenal gland. Next is the scrotal incision. There are various approaches to scrotal procedures, and the scrotal skin is quite elastic and incisions are easy to close. However, there are contraindications for this incision, which includes the presumed testicular malignancy and intrascrotal malignancy. Depending on the indication, a unilateral incision can be used in a transverse or vertical approach on the ipsilateral side. And if both sides of the scrotum is and if both sides of the scrotum, then a midline vertical incision is made in the median raft. Common indications include variococelectomy, hydrocolectomy, spermatocolectomy, vasectomy, scrotal and for testicular torsion, and orchidopexy. Next is penile incisions. Here, penile incisions are usually performed electively for correction of Peyronie's disease. And this disease is a condition when a fibrous scar tissue develops on the penis, causing a curved and painful erection. However, um, every urologist should have an approach to circumcision and penile fractures and distortions for prior person. And for adult circumcision, the most common used is the two incision sleeve. Next, for penile fractures and injuries, usually these injuries are explored via the gloving approach. This approach begins with a circumferential subcoronal incision, and the penile skin is then carefully peeled back to expose the corporal bodies and allow for exploration for suspected defect. The direct longitudinal incision might become more popular compared with the gloving approach. Next is the perineal incision. It is most commonly used as an approach to the proximal urethra and base of the penis. And common indications for this incision are urethroplasties, perineal urethrostomy, male urethral slings, inflatable penile prosthesis, artificial urethral sphincters. The urethral procedures under perineal incisions usually it is an 8 to 10 cm incision performed vertically beginning at the perineal scrotal junction. And the closure is usually multi-layered depending on the extent of dissection and mobilization. And the callus fascia should be closed before the skin closure to close the dead space and approximate the skin. Next is the radical perineal prostatectomy. It is done through a large inverted horseshoe incision, and the apex of the incision is about 2 cm from the anal verge, and the ischial tuberosities are used as landmarks here.
Okay, okay, Doktora, thank you for the very concise na lecture. Actually, parang self-explanatory naman yung mga incisions and mga axes. Yes, siguro yung question ko na lang, yung in-explain mo dun sa testicular, dun sa incision ng sa scrotal. So, if pag testicular malignancy, anong approach na gagawin mo dun for if you're considering a testicular malignancy?
Hello. Hello po.
Yes. Yes.
Sorry, Doc, naputol po kayo.
Naputol ba? So okay naman yung lecture natin as very self-explanatory kasi lalo na si kayo as incoming interns, medyo nagkaroon naman na kayo ng experience regarding sa mga types of incisions o chip nyo. So ngayon, para lang sinabi mo sa incision, contraindicated yung testicular malignancy. So for example, if you're considering a testicular malignancy, what would be your approach pag ganun testicular malignancy?
Siguro po orchiectomy. Radical orchiectomy. Ay,
No. Dr. Goa, alam ba ni Dr. Goa? Differential. Wala, may ibang nakaano, hindi orchiectomy. Anong incision? Yun yung tinatanong ko. Anong klaseng incision yung gagawin niyo if you're considering?
Sir, pwede po bang inguinal?
Sino nagsagot nun? Si Camille ba? Si Camille ba yung sumagot nun? Sino yung sumagot? Ay, ikaw nga. Oh, tama naman. Why? Bakit inguinal approach yung natin?
Sir, kasi naalala ko po parang isang conference nun, ayaw po natin ng surgical spillage po ba yun? Kalimutan ko na po pero po naalala ko po inguinal po sa one of our conference nung clerks po kami dyan, sir.
More or less kasi nga, di ba, pag yung testicular malignancy kasi, di ba, parang yung, saan ba galing yung drainage mo nun, di ba, sa may, para aortic nodes, yung mga ganun. So, ang gagawin mo, you have to approach it hanggang dun sa may inguinal ring. Then, mag-high ligation tayo. So, dun mo papadaanin. Hindi mo aanoin dun sa scrotal incision dahil nga, pwede mag-spillage. So, tama naman yun. So, okay. Okay, sige. Next week.
Tanong ko lang, sorry. Medyo swerte lang nakatatlo tayo ngayon. So, do you prefer 10:45 or 11? Or ang idea ko, Camille, i-inform na tayo beforehand kung medyo mahaba yung lecture. Ayoko ng backlogs katulad yung ngayon.
Sige po,
Sorry
sir.
na late kami kasi galing kami sa OR. So, sakto kami natapos 11. So, inform me kung medyo mahaba. Pag ganun, start tayo ng 11:45. Pag medyo, parang yung kanina, medyo light lang yung mga lectures today, baka pwede 11 para sakto isang oras. So, that's it for today's topics. Attendance tayo. May questions kayo, guys? Picture. Picture.
Ano nga yung shortcut ng picture? Shift. Command F3. Command F. Okay, picture. Hindi naman. Shift command.
Wait lang.
Hindi. Pindot mo na dito, tapos 3.
Shift command.
Tapos 3.
3. Okay. Isa pa. Okay, 1, 2. Okay, thank you.
Thank you. See you Wednesday.
Thank you po, sir.
Thank you, Doc.
Thank you, sir.